Good morning, everyone. I am Dr. Juhi from SGPGI Lucknow. So this session, themed as Classic Session on Vasculitis, has been crafted to deepen our knowledge and understanding about the role of cellular and molecular predictors in outcome of vasculitis, and also the impact of vasculitis on quality of life. I would like to invite Dr. Vishad Vishwanath, who is Medical Director, Consultant in IRIS, Trivandrum and Kollam, and Dr. Anupama Swami, who is Consultant Rheumatologist, Sagar Apollo Hospital, Hosmath Hospital, Bangalore, to chair this session. Also, we are delighted to have today with us Dr. Sutomu Takeichi with us, who is Vice President at Saitama Medical University in Saitama, and he is also Emeritus Professor of Kyoto University, Tokyo, Japan. And Dr. Gurmeet Singh, who is Associate Professor in the Department of Medicine, Government Medical College, Jammu. I would also like to invite Dr. Anurupa Vijayan, consultant at Dr. Shinoy's Care, Nettur, Kochi, for this session. Welcome, ma'am and sir. I would like to invite you to come up on the stage and take your seat.
Morning, everybody. It's indeed a pleasure to be here once again, discussing about one of the hot topics in rheumatology, that is about vasculitis. So we have 4 speakers. I invite the first speaker, Dr. Takeuchi. Sir will be speaking about the cellular and molecular predictors of outcome in large vessel vasculitis. Over to you, sir.
Yes, thank you very much for kind introduction. I'm very honored and pleasure to be here. Thank you very much again for the Debashish and the organizer for this Congress. My talk is the cellular and molecular targets and predictors of outcome in large vessel vasculitis. I would like to begin with this slide for the typical large vessel vasculitis, such as Takayasu arthritis and giant cell arthritis. In the left side hand, Takayasu arthritis, the name of Mingito Takayasu, the professor at the ophthalmology department at Kanazawa University. He described curious vascular disease in the retinal abnormality in 1908, more than 100 years ago. This disease is characterized by vasculitis with unknown etiology, affected aorta and its major branches. Loss of radial pulses are often observed, so that this disease is called as pulseless disease in Japan. And nowadays, registered patients since 1950 is around 6,000, but it's only 6,000. In contrast to Takayasu arthritis, giant cell arthritis on this right side hand, large vessel vasculitis also, characterized by giant cell granulomatosis affecting large and medium-sized vessels. About 40% of GCA have also polymyalgia rheumatica. Registered cases is around 2,000. However, recent years, the new cases for giant cell arthritis is much more than Takayasu arthritis in Japan. And so the giant cell arthritis is also a very big concern in Japanese population. And let's change the focus a little bit on the targets molecule in this large vasculitis. This is a very busy slide. However, you can appreciate here on the left side hand, the agent targeting on cytokines particularly, and the list of a variety of immune-mediated inflammatory disease on this x-axis. You may appreciate here in the systemic and Takayasu and giant cell arthritis, writing here. Anti-IL-6 receptor is working in these 2 large vessel vasculitis. However, there is no such a target at all so far. So we have now the tool to inhibit IL-6 receptor in these 2 large vessel vasculitis. So Daniel is the first author to describe the consensus statement on blocking IL-6 receptor and IL-6 in inflammatory conditions. This is a list for the IL-6 receptor and IL-6 ligand antibody molecule in the approved status. When you look at on this rheumatoid arthritis, JIA, etc., you can see here giant cell arthritis and Takayasu arthritis. Tocilizumab is approved in a variety of immune inflammatory diseases. Also, it is approved for JCA in US and Europe. It is also approved in Japan too. And Takayasu arthritis here. This is approved now only in Japan. But we did a clinical trial called TACT study. The efficacy of tocilizumab is approved. And so Japanese authorities approved tocilizumab in Takayasu. In addition to tocilizumab, you may appreciate here the sarilumab is now tested in phase 3 in giant cell arthritis. So this is the situation for IL-6 receptor agent. What about the IL-6 ligand agent? This sirukumab is also tested in phase 3 for giant cell arthritis. So that is a summary for IL-6 receptor and IL-6 ligand antibody molecule in the treatment of large vessel vasculitis. And then what is the dose? The dose difference between giant cell arthritis, Takayasu, and rheumatoid arthritis is because the level of IL-6 receptor is much higher for large vessel vasculitis compared to rheumatoid arthritis. So that the dose here is 162 milligram every week, not every 2 weeks. Every 2 weeks is the indication for rheumatoid arthritis. Instead, in large vessel vasculitis, you need every week subcutaneous injection of tocilizumab. That is the indication different from rheumatoid arthritis. So, what about the other targets or other molecule? In order to hunt the new molecular targets in large vessel vasculitis, we checked longitudinally the gene expression and serum cytokine level in patients treated with various kinds of treatments such as glucocorticoid and tocilizumab in our hospital. So this is a busy slide. We recruited total number 27 for large vessel vasculitis. The most of them are giant cell arthritis and Takayasu. You may appreciate here the comorbidities, giant cell arthritis, large vessel vasculitis involvement, etc. So particularly this giant cell arthritis 17. Among these 27, responder 18, non-responder 9. We set the healthy control. And this is the clinical cause of large vessel vasculitis, 17 GCA, 10 Takayasu. Because recently the new cases of Takayasu is very low compared to JCA. So that is a proportion of JCA and Takayasu is 17 versus 10. What about the relapsing-free survival is coming down right here. The most of them are treated with glucocorticoid with high dose, the initial induction therapy. About 40% of the patients received tocilizumab. So when then looked at the C-reactive protein level for week 6, 12, up to 60 weeks, in responder, that is the 70% of the total, is coming down rapidly at week 6. However, in non-responder, the level is not so low and maintain upper normal limits right here. So there is a clear cut that the initial induction therapy will control the disease activity inflammation in responder, whereas non-responder did not. Yeah, it is reasonable. However, you may appreciate here, this is a summary, and we checked the gene expression and serum cytokine level in each patient visit in these 27 patients. You may appreciate here the volcano plot. This is the level of gene expression. High expression is marked as red, down regulation is marked as blue compared to healthy individuals. Our top list is GMFGS and etc. here. You may appreciate here IL-1 receptor 1 is coming here. And then we did hierarchical clustering heat map. You can see GCA patients as marked as red in this X bar. Takayas is marked as green. Healthy control is blue. So this is a very clear-cut difference between healthy and giant cell arthritis Takayas right here. Upregulated gene is coming in large vessel vasculitis, whereas low in healthy controls. What is the gene in that upregulated pathway? You may appreciate here. The top one is non-alcoholic fatty liver disease. I don't know what is the reason why, but the second one, IL-1 and megakaryocyte in obesity, etc. The IL-1 as well as IL-1 receptor 1 may indicate of the role of IL-1 signaling pathway in large vessel vasculitis. So in order to focus on this much more detail, this is the genes and cytokines. Genes on the left side hand, cytokines on the right side hand. The rank of the AUC to test the validity of genes, cytokines at week 0, week 6, week 0, week 6 for cytokines, discriminating responders from non-responders. So the top list, for example, in cytokines, discriminating the responders and non-responders is IL-1 beta, the top line, at baseline, followed by IL-13, IL-4, IL-1 receptor antagonist, IL-10. And then at week 6, discriminating responder and non-responder, IL-1 beta is on top. These data may suggest that particularly cytokines discriminating responder and non-responder at baseline or even at week 6, IL-1 beta on top of the list. So these data may suggest us that IL-1 beta may be a good candidate as a therapeutic targets. Again, this is the longitudinal expression of genes and serum cytokines. Upper panel shows you the gene expression, lower panel serum cytokines. The responder as shown in green and non-responder as shown in red. Some gene expression like TLR2 or IL-1 receptor 1 is higher in non-responder compared to responder as shown in green, right here and right here. It is also true for IL-1 beta again. So these data again suggest that upregulation of IL-1 signaling pathway was one of the characteristics LVV that may be very good poor prognosis factor. Do we have any potential new targets for LVV? Yes. We have new GM-GMCS1 receptor data and JAK data too. So this is published in this year by Spanish researchers. GM-CSF receptor blockade with mavrilimumab is very efficacious in this report. As you may see here, the expression of GM-CSF is upregulated in GCA patient tissue right here. And also, IL-6, TNF, IL-1 beta, IL-6, TNF, and IL-1 beta is also coming down by blocking GM-CSF receptor, indicating GM-CSF receptor may be a good potential treatment targets. In order to test these hypotheses, they did clinical research, recruiting new onset GCA and relapsing GCA, randomized to receive mavrilimumab, anti-GM-CSF receptor monoclonal and placebo. This is the data showed you the time to first flare of GCA in all patients. As shown in red, the patient received mavrilimumab showed the better compared to placebo, statistically significant better results. You may appreciate here again the sustained remission rate of GCA. In patients received mavrilimumab, 83% showed sustained remission compared to placebo, 99.9%, statistically significant again. This is the phase 2 trial, so that we need to do such a data in phase 3. But this is a very encouraging data to us to much more forward. So this is a summary of the changes in circulating immune cells by treatment, like prednisolone, tocilizumab, JAK inhibitor, low-dose IL-2 listed here, and rituximab in case of Takayasu here. So the CD4 is coming down, Th17 is coming down. In case of tocilizumab, Treg is coming up. What about the CD8? It is variable depending on the disease. GCA and Takayasu. GCA, CD8 is coming up, Takayasu is coming down. The plasma blast is coming down, particularly in Takayasu by rituximab treatment. This is the changes in circulating immune cells by treatment. What about the tissue? This is a very unique study. They recruited 25 patients from inflammatory aortic aneurysm compared to non-inflammatory aortic aneurysm to look at the tissue gene expression. In this upregulated gene, the top one is immune cell response in the tissue of aortic aneurysm, downregulated here. This is a summary. By looking at the tissue gene expression from inflammatory aortic aneurysm, they may propose several interesting targets. Again, IL-1 targeting the top, granzyme B, S1PR5, interferon gamma, CXCL13, CXCL10, finally CNR2 targeting. So by looking at the tissue of inflammatory aortic aneurysm, unfortunately this is not from giant cell arthritis, not from Takayasu. However, this tissue gene expression may provide a hint to us. Again, IL-1 beta here. So this is the summary of all the data gathered. We published this data in autoimmunity reviews. When you look at the vessel wall and circulating status, giant cell arthritis here, Takayasu is here. The top list is the potential target or proven target is IL-6 receptor, IL-6. Maybe JAK inhibitors. I didn't show you the data of baricitinib in giant cell arthritis, but JAK inhibitor is next. Maybe anti-GM-CSF receptor, IL-17, IL-12-23. The finally, maybe IL-1 receptor antagonism may be efficacious in disease of large vessel vasculitis, such as giant cell arthritis and Takayasu arthritis. Thank you very much for your attention. This is my colleague in Keio University Hospital. Thank you very much.
disease.
Good morning. First of all, I would like to thank the organizers for this invitation and giving me a chance to present my talk here. So this is more of a bedside thing, what we see daily with our patients, the issues with the quality of life in these patients who have chronic disease. As is with any chronic disease, maybe diabetic or maybe chronic renal failure, most of our diseases in rheumatology, they are chronic, so these patients have a compromise in their quality of life. So coming to the vasculitis, around 50 years or 100 years back, vasculitis was a fatal disease, systemic vasculitis, especially the necrotizing vasculitis. And the primary aim of physicians at that time was to save the life of the patient. But now with better immunosuppression and better understanding of the pathophysiology, we are seeing the patients, they live very long, more than 10 years, 20 years. So the aim of, now most of the studies which you see, they will look also at the quality of life improvement with whatever drugs that you are giving. So this is the definition of the quality of life which the WHO tells us, but there is no need to know the definition. We all know what quality of life is from our experiences or our intuition. So this is actually a multi-dimensional feature. I mean, there are different aspects or domains of quality of life, the physical, functional, emotional, social, economical. So these all contribute and different strengths to overall quality of life in a given patient. In some patients, you may have more compromise in physical. In some patients, the psychological is more compromised. So who is the person who can tell you about the quality of life of the patient? It's the patient itself. I mean, patient is the best person to know what they are suffering. The physical quality of life is best described, and it is affected by the vasculitic symptoms, how severe the disease is, which organ system the patient has most involvement of, and what are the drugs which you are giving, and what are the side effects of these drugs. Because sometimes patients are more worried about the side effect of the drugs rather than the disease itself. And some studies have shown that there is actually a weak correlation of physician-rated disease activity with the quality of life scores. Then there are associations of quality of life with mood disorders. This is the psychological part or psychiatric morbidity in these patients which we see. Any chronic disease can affect the psyche of the patient, and the patients may have worries about the disease itself or the outcome of the disease or the management or the side effects of the drugs. Then another is unemployment or sometimes underemployment. A patient may not be able to give their best to their what they are capable of, so they may underemploy themselves to cope up with the disease. And then there is fatigue part. The fatigue is one very important feature which we see daily in our clinical practice. Patient says that mostly in rheumatoid arthritis, patient comes to you and you see that there is no tender or swollen joint, but the patient complains that I am tired at all the times, I am not able to do my job, or I am not able to do the household work which I should be doing. And there is a association of fatigue with pain, anxiety, and depression. So this is rather a feedback or positive feedback loop which occurs in these patients. Patients have fatigue, they have depression because of fatigue or fatigue because of depression, and this aggravates the pain that they feel. Because there is increased sensitization at the central level because of depression or anxiety or fatigue. So these patients will feel more pain than a patient with similar disease and no depression will feel. And there is increased prevalence of steroid-induced osteoporosis, thyroid disease, bronchiectasis, especially in GPA. So there is a multiple contributions coming to affect the quality of life, which is a singular output of many inputs. And it has been seen that quality of life in patient vasculitis, the impairment is as high as what you see in chronic kidney disease or in rheumatoid arthritis. Then coming to fatigue first, it's a major problem, and most of the patients, rather 3/4 of the patients with vasculitis, they have fatigue along with itself, and patients are more than twice than likely than controls to report some form of fatigue, maybe mild or moderate. And it's a very important predictor of physical health. Somebody is fatigued, the patient may not be able to give the best, or may not be able to focus on what they are supposed to do in their job or maybe in their household duties. And these patients, they complain of reduced energy levels. This could also be because of underlying psychiatric morbidity in the form of mild depression, which you are not able to pick up. But fatigue and depression, they go together. And it affects the other domains of quality of life. And patients, they say that they are worse off because of their fatigue. And again, pain, another feature which occurs in most of the rheumatological disorders, it's the pain which brings the patient to rheumatologists. So we are sort of pain doctors, rheumatoid arthritis or SLE or vasculitis itself. The pain patient, the perception of pain depends on many things. Like in fibromyalgia, you have increased perception of pain. In any chronic disease with underlying depression, patient may have more pain. Then coming to the physical changes, these are very important. In systemic vasculitis, you can have multiple organ involvements at a given time, or in sequentially. Sometimes patient has one organ involvement, you take care of that. Patient comes up with the second organ system involvement, like hearing loss, headache, shortness of breath, decreased kidney functions. And along with it, the patient has altered physical appearance, like weight loss because of any chronic vasculitis, saddle nose deformity, ulcers. Then the body changes or the physical appearance can change because of steroids, weight gain, moon phases. Then because of treatment part, patient may come up with hair loss, hair growth. So these may appear very trivial when compared to systemic vasculitis. You will say that hair loss was the big deal, you are only losing some hair. But this does not go like this. There are many patients with rheumatological disorders. Once you start them on DMARDs, they have hair fall. They'll come to ask you whether this hair fall is because of some drug or not. And you tell them, yes, this is because of methotrexate. And they would say, no, we don't want to take these drugs because we are not very comfortable with this hair loss. So you tell them that the next drug that we give is more costly and more toxic as compared to methotrexate, and they are willing to take this drug. So patients are, especially the females, they are not worried about their appearance. And same thing you must have observed with hydroxychloroquine. If you tell the patient that we'll give you a drug which will cause you tanning and darkening of your skin, many patients will straight away say that we do not want these drugs. This I've seen many times, and you must have seen. So patients are willing to get damaged joints or severity of disease, but not dark skin, but not less hair. So never underestimate patients' perception of their body functions. And similarly, you can have acne, mouth sores because of drugs, and you may have to change the treatment. And all these physical changes, because when the patient gets up in the morning and looks at himself or herself in the mirror, they see a different person than what they saw at the start of treatment. And the patient may not be able to see their kidneys or their lungs in the mirror, but they see their persona in the mirror and they say that it is deteriorated. So they are not worried about these changes. So Physical function, again, patient have poor physical functions compared to healthy control that is expected. And for this reason, they may have to cut down the time spent on work because they will find that they are not able to give their best. And sometimes even outside their jobs at home or with this, they have compromise in their social interactions or their familial interactions also. And some of it may be because of difficulty in undertaking daily activities like showering, shave, chew, walk, or go alone, go upstairs, come down upstairs. So change in the balance functions. Then psychological quality of life, this is very important. This is sometimes more important than their physical quality of life. So if a patient has this compromise, you will find it very difficult for the patient to stick to the treatment that you are giving. And it has been seen that depression and anxiety may be seen in more than 50% of the patients with vasculitis as compared to less than 10% in general population. Then psychological, so we are talking about impairment in quality of life, but paradoxically it has been seen that some patients may have improved quality of life or happiness. This was seen in a study, and the reasons suggested are that patients, once they get a chronic disease, they come to know of their prognosis, they reevaluate their lives and priorities after the diagnosis. And patients who recover from bad relapses, they appreciate what every extra day that they are getting means to their lives, and they sometimes become more calmer as compared to before. Then financial quality of life, again, when somebody is ill, you have to make expenditure to cover for it, like direct medical cost or indirect cost like employment curtailment, income reductions because of sick leave, mixed work, modifying their jobs. So many patients, they report disease-related income reduction by around 50% or up to 75%. And this was seen in Takayasu arthritis. Half of the patients, they had to change their work duties. And some of the patients, they had to sit at home, resign from work because of their disease. So here I have compared around 3 studies. This is important as far as the relations are concerned. So if you see these 3 charts, you will find that in most of the patients, there is either no change or improvement in relationship. So around 70 to 80% of patients in these studies reported that they had improvement or no effect in their spouse relationship. Same thing with family relationship, around 70 to 90% of patients, they had improvement or no change, so only 10% had worsening relationship. Then coming with the relationship with the friends, again no effect or improved, most of the patients. But this is one aspect, this is the social aspect. You have psychological, environmental and physical aspects of the quality of life domains. So let's not forget the effect the disease has on carers, because in any chronic disease, there is some limitation of locomotion or whatever activities of daily living. The burden falls on the carers. So they carry a heavy burden and they may require support on their own. The carers may themselves require support, because once a patient, a family member is not well, the burden falls on somebody else. The grief or the anxiety is shared among the family members. So you also need to look at the carers to see whether they are not getting exhausted or fatigued. The management is that psychological, like cognitive behavioral therapy or psychotherapy, which you say, making the patient realize their prognosis, how better to manage the disease are important factors. And there comes the function of a combined team or a combination of a team effort to look at the various aspects. A rheumatologist will look at the disease part, the psychotherapist, the physical therapist, physiatrist, they will help in the exercise programs. So coming to the conclusion, the vasculitis affects several domains, some more, some less, but most important to look at is the psychological domain, because that is where you can have intervention, because all the drugs which you are giving, they control the physical part, but the psychological part is usually missed. And the physical health influences mental health, and the reverse is also true. A poor mental health will result in a poor compliance and poor disease management. And so this is a fundamental, this is a multidimensional construct of quality of life. So these are some of the studies which we have done at our centers looking at the quality of life in various patients. We have not looked at vasculitis, but we have looked at fibromyalgia and rheumatoid arthritis and found that there is a lot of anxiety and depression in these patients, which affects the quality of life in these patients. Thank you.
So we have to go beyond immunosuppression and take help of non-pharmacological ways to address the lifestyle issues to improve the quality health of patients of vasculitic disorders. We have BVAS and other responder indices for us to see the quality of disease, see the disease activity. And we as health providers or physicians, we are more focused on the disease activity and things like premature mortality. But from the patient's point of view, the quality of life issues become more pertinent to them. And here we need more PRO measures, that is patient-reported outcome measures. That will give us a patient global. And that is very much required, but that is very difficult to form in the vasculitic patients because it requires a high level of engagement from the part of patients. I think we will be able to do it in future. Thank you, Dr. Gurmeet Singh. Now the house is open for questions and answers. If you have no question, I have a question for Dr. Takeuchi. Sir, you said that there is upregulation of IL-1 pathway in cases of giant cell arthritis, probably refractory ones. So, is there any use of using anakinra in such patients?
What is the question again?
You said that there is upregulation of IL-1 pathway.
Yeah.
And so, is there any use of anakinra, the IL-1 receptor antagonist?
Yeah.
Is it useful in such patients?
Yes, maybe the IL-1 beta antibody is useful to test the clinical efficacy. We already have the anti-IL-1 beta monoclonal antibody. That is the one candidate for the test. The second one is IL-1 receptor antagonist. Now, that is also available. But a monoclonal antibody is every 4 weeks injection. However, IL-1 receptor antagonist is every day. So that's we favor the monoclonal anti-IL-1 beta antibody. That should be tested in the clinical trials.
Yeah, thank you very much. And I think in Japan there is a lot of work going on to find a biomarker from peripheral blood cells, immune cells from the peripheral blood cell. So can you please throw some light on this?
Yes, the much more easy way as a biomarker is measuring the level of cytokine rather than checking the immune cells. So we are now proposing IL-6, IL-1 beta, and other cytokines like TNF-alpha. IL-1/6 is very easy to measure. However, IL-1 beta as well as TNF-alpha is very much low in the content in the serum, so that it is very difficult. So IL-6 could be biomarker. That may be the very good biomarker for measuring the disease activity. Thank you.
Thank you. Anybody has a question?
May I ask?
So if
May I
that's
ask a question?
Yes, please.
Is it all right if I ask a question?
Yeah, yes.
Dr. Takeuchi, thank you for your presentation. Actually, I have been struggling with these biomarkers
in Takayashu for a very, very long time under Dr. Dandal's supervision. So the problem is I have not been able to replicate anything across multiple patient, you may say, subgroups. So we have tested IL-6 multiple times. In one small study, it comes significant. In another bigger study, even bigger study, it is not coming significant. In fact, none of the biomarkers are associated with disease activity. And second thing is regarding transcriptomics. How far do you think is blood cellular transcriptomics is going to give you the true representation of what is happening with the tissues? In the tissue, I am talking in terms of only Takayasu arthritis.
Okay, thank you very much. For the first question you asked is, I feel same way. We definitely need a biomarker for large vessel vasculitis or any kind of vasculitis, because only CRP is not enough. Because you treat the patient with glucocorticoid, CRP is coming down. However, the disease is there, still there in the vessel. So at present, we only need the imaging for the vasculitis for following up. Definitely we need biomarker. So that's why we did such kind of study. However, as I mentioned, still IL-1 beta is lower. It is very difficult to look at correctly. So we are now trying to find a much better the biomarker, particularly the serum biomarker. The gene expression are obtained from patients' cells. And we need a hard work to look at the gene expression by gene chip, time consuming as well as money consuming. So I think the best way to find biomarker is the serum protein. But so far, I did not find the very good candidate, as you suggested. So for your last question, I feel the same. The gene expression is a little bit difficult.
Okay, thank you. Maybe the rest I'll talk to you later.
So now can we go ahead with the next session? Can I ask Dr. Anurupa Vijayan from Kochi to start the brainstorming session?
Good morning all. The next section is a big question, that is, can serial ANCA level estimation predict relapse in ANCA associated vasculitis? This has been a question of debate for the past 30 to 40 years. So we'll start this session with two case scenarios that we usually come across in our clinical practice. First is a diagnosed case of GPA on the basis of multiple consolidatory patches, nephrotic range proteinuria, scleritis, and anti-PR3 positivity. This patient was treated with rituximab induction and 6-monthly maintenance therapy. And now the disease duration is 4 years. And patient is in clinical remission, but his PR3 is negative and CD19 is 0. The second case is again a case of GPA with migratory joint pains, mononeuritis multiplex, anti-PR3 positivity, again treated with rituximab induction and maintenance, 3 years of disease duration. Patient is in clinical remission, but PR3 is elevated and CD19 is repopulated. The big question here is whether to continue rituximab or not. So ANCA-associated vasculitis is associated with significant morbidity and mortality. So the prediction of relapse is important because this will enable us to have a tailored therapy, mitigate the unnecessary drug exposure and treatment-related damage. So this is one of the earliest reports of using autoantibodies against neutrophils and monocytes as a tool for diagnosis and marker of disease activity in vaginous granulomatosis. This was published in Lancet way back in 1985. In this study, 41 patients of vaginous granulomatosis were included, and what they found that IgG autoantibodies were directed against the extranuclear components of the polymorphonuclear neutrophils in 25 out of 27 patients when they were having active disease. But when the patients were having inactive disease, only 4 patients were positive for anti-cytoplasmic antibodies. And this diagram shows a correlation of vaginous clinical disease activity with the anti-cytoplasmic antibody titer. So this concluded that anti-cytoplasmic antibodies may correlate with disease activity. So this study looked into the serial measurements of ANGA in patients with systemic vasculitis. This included 43 patients followed up for 2 years. The important results were relapse occurred in 23 out of 43 patients, and the relapse was found to be higher in persistently positive ANGA when compared to that of negative ANGA. And the important conclusion made was persistence of ANGA positivity can be associated with relapses. An increase in the ANGA before relapse occurred in 33% of the cases for anti-PR3 and 73% of the cases for anti-MPO. But the positive predictive value for PR3 ANGA in predicting a relapse was only 28%. So this made the conclusion that an increase in ANGA titers should not be used as a sole parameter for predicting a relapse. And this is one of the important meta-analysis that looked into whether a rise in ANGA or a persistent ANGA can predict the relapse. So 9 articles on a rise in ANGA, 9 articles on persistent ANGA elevation were included. The overall likelihood ratio of rise in ANGA for predicting a relapse was 2.84, and for persistent ANGA it was 1.97. So this concluded whether if there is rise in or persistent of ANGA during remission, it is modestly predictive of a future disease relapse. So now we know we are using rituximab as the main therapy for ANCA vasculitis. This study looked into the long-term follow-up patients who received repeat dose rituximab as maintenance therapy for ANCA vasculitis. 69 patients on ANCA vasculitis on rituximab induction and maintenance therapy were selected, and the risk factors identified to relapse from this study were baseline PR3 positivity, prior relapse, switch from ANCA negative stage to positive stage, and early reconstitution of B cells less than 1 year. And this study is from the RAVE trial, where they tried to look the factors determine the clinical utility of serial measurements of ANCA against PR3. So after complete remission, serial measurements by direct and capture ELISA were analyzed in 93 patients with PR3 ANCA positivity. Results: an increase in PR3 level occurred in 62.4% of the patients. Relapses were seen in 59% of patients. An increase in PR3 by direct ELISA was associated with subsequent severe relapse in patients with renal disease and alveolar hemorrhage. And relapse was more in the rituximab group. So a risk of subsequent relapse may be dependent on the PR3 ANCA methodology that is used, the disease phenotype, and remission induction treatment the patient received. This is a single center cohort study where 110 ANCA positive patients were treated with rituximab were included. Serial ANCA and CD19 B cell status were also included in the study. And what they found that reappearance of PR3 ANCA positivity was showing high specificity of 92% for predicting a relapse. So absence of PR3 or MPO positivity is highly predictive of a relapse-free state. In PR3 ANCA positive patients, 96% of the relapses occurred with persistent or reappearance of PR3 and 81% with B cell repopulation. But in MPO ANCA positive patients, all the relapses occurred with persistent MPO positivity and B cell repopulation. This is one of the recent meta-analysis that was published by our Indian authors, Dr. Pankti Mehta, Anu Palakrishnan, and Zakir Ahmad et al. They tried to see the sensitivity and specificity of positive ANCA as a predictor of relapse. It was found that ANCA for prediction sensitivity was 0.7, specificity of 0.6, positive likelihood ratio of 2.1, and negative likelihood ratio of 0.4. Positive or rising ANCA and relapse, the overall hazard ratio was found to be 3.11. So this study supported the modest accuracy of ANCA in predicting relapse of ANCA vasculitis and supports the use of serial ANCA monitoring as a biomarker for relapse. This meta-analysis tried to see the gap between the ANCA rise and the relapse. So they looked into the ANCA rise and relapse within 6 months, 12 months, concurrent relapse. So ANCA rise with a relapse occurring within the 6 months is having an odds ratio of 3.65, and relapse occurring within 12 months was having an odds ratio of 2.8. But the chance of concurrent relapse is very less with odds ratio of only 0.1. When a patient is having active disease flare, the chance of ANCA to be positive is very high with an odds ratio of 10.8. So conclusions: when a patient is on rituximab maintenance therapy, ANCA reappearance or increase in titer of ANCA, and especially anti-PR3 compared to anti-MPO, is frequently associated with relapses. And when there is a rise in ANCA, relapse usually occurs within 6 months to 1 year of ANCA rise. And when B cells are undetectable and ANCA remain negative, the chance of relapse is rare. So our first case, this patient was in clinical remission and PR3 is negative, CD19 is also 0. So whether to continue maintenance therapy in this patient, actually we can hold the treatment and we can keep the patient under follow-up. But in the second case, this patient is having PR3 elevation and also repopulation of the B cells. So it is better to continue treatment with rituximab maintenance therapy. Thank you.
We had 3 very interesting sessions on vasculitis, really packed with science. We had Dr. Tanashi speaking from Japan, one of the cradles of research in vasculitis, who gave insights into the newer pathogenesis of Takayasu arteritis. And it's indeed exciting to see that, in fact, large vessel vasculitis are one of the diseases which are very refractory to treatment, and it's exciting to see that newer targets are coming up, potential targets are coming out, and research avenues are opening up. And Dr. Gurmeet reminded us of the fact that we should not just treat the disease, we also have to look into who the person is, address his anxiety, fatigue, and other domains which may actually be related with affecting his quality of life. And Dr. Anduba talked about the relevance of ANCA testing, seal ANCA testing, about which I'll mention a few, add a few more words. So, a value of a diagnostic testing reflects on how well it reflects the disease pathogenesis and how good is the methodology of testing. So, ANCA testing is currently the only non-generic marker which is used in disease monitoring in ANCA vasculitis, and predictive efficacy we can say is modest. However, there are suggestions that especially in patients on rituximab treatment, it would be helpful in monitoring treatment and suggesting a role for the B cell pathway. What we are increasingly realizing is that the pathogenesis of MPO negative or the ANCA negative and ANCA positive vasculitis may be different, and there may be different role because the pathogenesis is different. And not only that, the pathogenesis of ANCA negative and ANCA positive are different. Even within the ANCA positive vasculitis, the pathogenesis is different with respect to different organs. So it is only natural that we are not able to attain that perfection with just monitoring one biomarker naming PR3 or MPO. And what is also we have to remember is the diagnostic limits of existing ELISAs, and perhaps better testing capacities, tests with better testing capacities can increase the sensitivity and pickup rates of ANCAs. So I would like to conclude this session. I thank all the speakers who have very gracefully taken part in the session as well as in the discussion. Thank you all once again.
I conclude that this session is over. Thank you very much.